So Ryan, bring us home. Tell us about what you think are the more promising emerging approaches. I guess we've heard about TIL, we've heard about triple, BRAF/MEK immunotherapy. What do you like?
So I think, it's what I like and what I think is coming next are probably in line, and then there may be some of the things that I think could also be in the future. I think the things that are, if the data with TIL therapy, for example, which in a albeit selected population, 66 patients, they obviously had to have a tumor that could be resected. They had to be able to grow the TIL, and then they had to be well enough 3 or 4 weeks later to receive lymphodepleting chemotherapy and then get the TIL product and the IL-2. But the response rate in a heavily pretreated population, everybody had PD-1 inhibition, 3/4 or more had CTLA-4 inhibition, the 36, 37% response rate is totally respectable. The waterfall plot definitely inflected past 50%, meaning most patients had some tumor regression. There's a 75 or 80 patient cohort. And if there's a similar response rate seen in that cohort, I would anticipate that would be FDA approved. And that's exciting. And anytime there's a new potential drug that could be approved, that's exciting. I think at centers, Jeff, you're obviously an expert at giving TIL therapy. Not most of us aren't, but fortunately, CAR T-cell therapy has forced all of our institutions to rethink delivering cells to patients. And so I think it actually, 10 years ago, this would have been a hard thing to roll out. I think now it'd be a relatively easy thing to roll out. And so I think that's one thing that came out of this. It was reinforced data from, that was updated from last year, but data nonetheless that is encouraging and likely speaks to a near future change in the way we manage patients in the refractory.
Ryan, can I make one more comment quick on that? So the other data from it that I was impressed by in this update was that when you looked at the responding patients to lifileucel or the TIL product, they disproportionately were people who were outright refractory to PD-1. And when we go back to what Adil said earlier about wringing out all the T cells, these are patients that do very, very poorly. And the idea that they have a disproportionately more active agent for that population of patients, to me, makes this a high priority. I'm actually really excited about this because I feel like these are the patients that we have not advanced the field for. We've done really, really great for some of the patients, but these patients we have not made progress. And maybe this is it. I mean, we'll have to wait and see. We still need more data, but it's
and the other point that Adil made was that we need to see how durable the responses are. In fairness, the duration of response with 18 months of follow-up hadn't been met yet. Certainly, some of these responses were very transient, and by 4 or 5 months, the response was gone, and patients had progressed and either onto something else or unfortunately not onto something else. But the majority of patients, those responses were lasting 18 months or longer. So, I think this is sort of it's a commercial product. It's something that we might be able to use as soon as it gets, if it gets approved, as soon as it gets approved. I think it's exciting data for a population of patients that don't have a lot of exciting data. I think the triplet therapy, so BRAF/MEK, PD-1 or BRAF/MEK, PD-L1, boy, this is a decade in the making with phase 1 and phase 2 trials that many of us were part of. And then to see, an idea that BRAF targeted therapy causes changes in the tumor microenvironment, maybe adding immunotherapy would be useful. And ultimately, it seems like it might be. And in the frontline setting, there seems to be an improvement in progression-free survival. There seems to be an improvement in duration of response. And that's not just in a randomized trial that we talked about before, the IM-SPIRE 150 or the Trilogy study, which is them-Cobe lead in for 28 days, and then you add atezolizumab. There's also dabrafenib and pembrolizumab study that was randomized and showed an improvement in progression-free survival and a trend towards an improvement in overall survival in patients who received triplet therapy versus doublet BRAF targeted therapy. Also updated at this presentation at ASCO this year was the COMBI-I study. It's a randomized trial that part hasn't been updated yet. That data has not been released. It's not mature yet, but the randomized, or rather the non-randomized phase 1/2 data shows a complete response rate of 44%. That's a remarkable number. If that's true, if in the randomized data you get a complete response rate in the 35 or 40% range, that's dramatic. And again, we anticipate that would meet the primary endpoints of progression-free survival. Ultimately, where that fits, I don't know. That's not comparing against PD-1 inhibitor therapy. That's not comparing against ipilimumab or nivolumab. So well, at least have things to argue about at our meetings for the next 5 years until somebody does that type of study. But it's still another option. There are patients who are BRAF mutated that we give BRAF mutant, or we give BRAF targeted therapy to because we think they're going to die 2 weeks from now. Now we can offer those folks BRAF targeted therapy plus PD-1 inhibitor with some hope that they'll do well. And, you know, I think that if we have BRAF, MEK, PD-1, PD-L1 studies, I think that seems likely that that's another thing that could get to the clinic. I mean, we obviously can all do it off label, but I think that's something that could be approved, you know, in the next year or two as well. And the more options we have, the better, I think. In terms of other things, I think there's personalized cancer vaccines plus PD-1 inhibitors. We'll see where that goes.
What about the thing that Jason mentioned? He talked about Pembro plus a non-toxic partner. What about NKTR214 or
Sure. You know,
Aldesleukin?
IL-2 is an old drug. Bempeg aldesleukin is a modified version of an old drug which has a bunch of pegylations on it, which have been shown that it seems to preferentially target the receptors on the T effector cells and the NK cells as opposed to the T regulatory cells. The data is single agent, you know, compelling in terms of you can see what changes in tumors, but not so compelling in terms of single agent efficacy. But in combination with PD-1 inhibitors, it seems like there's something there. Whether that's so much there that you end up with a positive phase 3 trial, I don't know, but we'll find out because that phase 3 trial is ongoing. That's nivolumab plus or minus Bempeg. There are other IL-2 analogs that are out there now too. We'll just have to see where that part of it goes. I mean, you know, it's a compelling concept to use IL-2 because it really did set the bar for potentially curative therapy in melanoma. It just was a low bar. Yeah. And the question is, if you add that to PD-1, do you really, you know, raise the bar further, or are you just treating the same patients that were going to do well with PD-1 inhibitor? I guess we'll find out. But again, you know, it's exciting that these trials are out there and that they're testing, asking these questions, and hopefully we'll answer them.